All right, here we go. NSCA Essentials of Personal Training, Chapter 20. And we're in presentation 2. We're talking about MIs, myocardial infarction, stroke, and peripheral artery disease. When we jump into this, the three of these things, they have the kind of the same root cause, if you will, the same pathology. And it is an occlusion of blood flow to the heart, could be to the brain, could be to the peripheral cardiovascular system, when plaque forms on the wall of the blood vessel, and that's atherosclerosis, if you remember that. Now, the book provides this example over here to the right, which you probably want to become accustomed to or become friendly with. When you have an atheromatosis, which is a lipid cholesterol plaque that forms within the lumen, the inside of the actual blood vessel itself, that plaque, if you will, causes a disruption of blood flow, and it disrupts laminar flow. Laminar flow is this. When we look at laminar flow itself, let me open this guy up here. This is an example of water coming out of a drain, and the water itself is flowing very smooth until the individual sticks their fingers in the water, and you see the water flow become disrupted. And I like this how they talk about laminar flow is where fluid moves in a smooth parallel layer without mixing or turbulence. So just imagine you have blood going through the vascular system, and it hits some type of disruption or blockage in the lumen, meaning within the actual open area, and that causes turbulence. Let's see if we can get this guy to play. And it causes this turbulence like the fingers. Right there, you can kind of see how it would just disrupt the flow itself. When we look at this now in terms of blood flow, those eddies or that current that's caused, that's going to cause more disruption and cause more, if you will, more lipids and more cholesterol to actually adhere to that wall. So it becomes a negative cycle. And you have this kind of collagen cap that develops over that inflamed area, which causes a further reduction in the diameter of the vascular system. Now, what you don't want to have happen. So when you talk about this in terms of you have A, B, and C here, when it's nice and smooth, you have blood flow that's going right through the system without a problem, going right through the vascular system. And what happens is as you end up with going from this to this to this in terms of having a couple things happen, a collagen cap on the inside edge of the lumen, it basically disrupts the flow of the blood. And this disruption of flow causes this disruption, causes more turbulence, and that turbulence itself brings kind of like this settling of sludging, if you will. And that what ends up happening is you end up with a thrombosis, which is a clot. And that thrombosis can either be in the vascular system, as we noted, it could end up in the heart, or it could end up in the brain as a stroke, neither of which are great options. Now, when they talk about this, you have this occluded part that breaks off and flows downstream to a more distal site, and they talk about how that can cause a stroke, right, or an MI. And as we take a little bit further down, once you have a mature collagen cap, it kind of stays in place a little bit better than a newer one, but still you have to be able to understand that a person can, quite frankly, die from a thrombosis or have very negative effects if that thrombosis goes to, say, like in the lower extremity into the calf, and you end up with a deep vein thrombosis in the calf. Now, the collagen cap itself, I want to find this part here. When it ruptures, you have this release of this material, and sent flowing can cause an acute MI or cerebral vascular accident, which is a CVA. And you have individuals where if it goes into the heart, that causes blockage in the heart. Now, the heart requires blood flow, right? It requires circulation because the heart requires oxygen. It is a muscle after all. And when you have that blockage in the coronary arteries, you end up with angina. Angina is chest pain due to insufficient blood flow to the heart. So it's not like you're having a broken heart, right? But you end up having a heart itself that has occluded blood flow to a part of it. And in essence, what's happening is that part of the blood is being starved of oxygen and is, in essence, dying. And that's where the pain comes from, that angina in the chest. So with the risk factors, the book notes this, take note as well. The risk factors for atherosclerosis include diabetes, high blood cholesterol, high blood pressure, obesity, tobacco use. Sound familiar? Family history, lifestyle, including nutrition and dietary choices with lower exercise and lower physical activity. These are all things that should sound very familiar to you. And we talked about them in a previous presentation, and we've talked about them at length when we've done our case studies. They all kind of tie together. And so people who are obese, you think about it, even though the fat is going along for the ride, that fat still needs blood supply. And so people who are obese require more blood vessels to feed the adipose tissue, and this effectively increases the cardiac workload, affecting the circulatory efficiency of the heart's pumping action. So a person who gains weight is not only working harder muscularly, but they're working harder cardiovascularly as well. So specific to cardiovascular disease or coronary artery disease, when a person has a blockage, an occlusion of blood to the heart, that causes that pectoralis angina. That's that pain that we were talking about in the heart. And the myocardial infarction that they note here is the dying of the cardiac muscle. And that dying of the cardiac muscle causes that very intense pain that people have when they have a heart attack, which is pectoralis angina. When we look at, people that you might work with, I have no doubt when you're working with clients, you're going to have a client who has probably had some heart attack. They probably had some type of intervention. It could be medicinal in terms of pharmacological, or it could be perhaps a surgical intervention. More than likely, in either case, they've gone through some type of cardiac rehabilitation program, and when they get to you, they should be good to go. And they will be very, very aware of their condition, and they'll be very, very able to articulate when they're not feeling good, when they're feeling better, and be able to note some of the adaptations that they'll have to your training with them. With initial training for somebody who's post myocardial infarction, you're looking at doing immediately that type of work in a cardiac rehab setting, and it's going to be under the supervision of a physician. Thereafter, you may have some very specific interventions that are provided to you as a trainer that you can implement into a training program. But most often, at least the people that I've come across, if they've graduated from a cardiac rehabilitation program, they're pretty much given the GTG, they're good to go. And they can work out with the understanding that we're not putting that person through a soul-crushing workout the very first time we meet. There's incremental progress towards increasing both duration and intensity of the workouts as we progress. With some of the exercise guidelines, they talk about stroke in here, and they also talk about some other things regarding peripheral artery disease. The big takeaway that they have here is with a cerebral vascular accident, which is a stroke, is a brain injury caused when blood flow to an area of the brain is cut off by either a blood clot or bleed due to a ruptured blood vessel. And that'll be reflected somewhere else in a quiz question or test question. But when they talk exercise guidelines for post-MI clients, what I want to really point out here is on the left side of this this excerpt from our book, they're talking about clearance from a cardiologist first, and they're talking about you as a trainer should be aware of some abnormal signs and symptoms like shortness of breath, pain in the chest, signs of a heart attack. But I can tell you that your clients will be very, very well aware of those signs and symptoms, and they'll be able to articulate those to you easily. And as they go through and kind of give you some suggestions here, they might provide, like I mentioned, a MET level or a VO2 that you should do with the client. But to a certain degree, again, when your client ends up in front of you, post-MI, they usually have already received some type of clearance to go and work out. Now, the recommendation that they make is for aerobic conditioning to be 3 to 5 days per week, 20 to 60 minutes at a time at intensity to 40 to 80, or a RPE of 12 to 16. Now, and I just want to point out, when you're talking about 40 to 80, at that 80%, we're not going over that anaerobic threshold. We're still keeping the exercise fairly aerobic, right? And you know you're going to work with your clients. You have to push them along, and the heart is a muscle, and you have to actually get the heart muscle to adapt to the stressor you're placing on it. But again, it has to be done in a way that's both proper and prudent, and you're not going to blow the person out of the water. I do have this on the bottom here. Exercise program for post-MI clients should include monitoring signs for cardiac issue. I talked a little bit about that, but some of the stuff that they note here, and you've seen some of this in one of the other book or the slides previously, is just look out for, if there is a cardiac issue, if they have shortness of breath, chest pain, pectoralis angina, is there pain in the arm? Are they, having heart palpitations? Apheresis is another one you have to look out for. And it's just a matter of making sure that you are aware of your client and any conditions that they might be having at that time. There we go. So I'll say it again. Much like your clients with diabetes, much like other clients with other medical conditions, your client will know that they have a condition, and they've probably have been well versed by their doctor. And as a result, you can feel pretty comfortable working with them, but doing so in a way that is logical, progressive, and makes sense in terms of for your client having the best situation that pushes them, but not to the point where it goes beyond what their capabilities are. All right, I'm going to sign off of this one and go on to the next one.